Hello and happy Teach Me Tuesday. My name is Lisa Houston, and I am a NICU nurse and a clinical educator in the NICU, bringing you NICU education for NICU nurses from novices to experts, the whole spectrum of education. It is February, which is Heart Month, Heart Awareness Month, and this week, February 7th through 14th, is Congenital Heart Awareness Week. During this week, we're going to be talking about different congenital anomalies, but first we are going to talk about our cyanotic congenital heart defects. And then on Thursday, come back, find us again. We're going to talk about our acyanotic congenital heart defects. As we get started, I wanted to remind you that cyanotic heart defects are those ones that cause reduced oxygenation to the blood, leading to cyanosis, right? That bluish coloration of the skin. We're going to talk about on our next slide when we talk about normal blood flow, kind of what that means. But typically either there's something switched or there's a hole in something that allows this improper blood flow throughout the heart. We know about a lot of these in utero, which is great, but we don't know about all of them. And in fact, I'm going to give you some real life examples of situations that have happened to me as a bedside NICU nurse throughout my career. We also need to have this early recognition. This is also why we do our CHDD, our congenital heart defect screening, prior to infants going home, so we can see, especially for those defects that are dependent on the ductus arteriosus remaining open, if they have closed. We are going to cover 7 major cyanotic heart defects. We cannot go through them all. I'm going to be sharing a lot of things on my Instagram page and here and other locations about great resources for you. There are apps, there are wonderful websites such as CHOP, Cincinnati Children's, the Mayo Clinic, that go through everything you could possibly see, but I wanted to give us an overview of the 7 most common. Prior to doing that, let's talk about what is normal blood flow through the heart. To be honest, the way I got good at this was by repeating this to myself over and over again, because repetition is how I learn best. So I encourage you to find something that works for you, whether that's videos. I will be linking on my Instagram page some videos that I really enjoy that really help me understand the blood flow through the heart. But when we think about this, we're going to think about how our blood comes back to the heart via our inferior or superior vena cava, and it's deoxygenated, right? It's done its job. It's dropped the oxygen off, it's picked up its carbon dioxide, and it needs to take that to the lungs so that we can exhale it off and pick up the oxygen. So in order to do that, the blood passes through the right atrium into the right ventricle, and it goes up into the pulmonary arteries. Remember, arteries are away. They take the blood away from that atrium and into the lungs. They're going to go into the lungs. They're going to do their job, right? We're dropping off our CO2. We're picking up our oxygen. We're going to come back into the lungs into the heart via the pulmonary veins. It goes into the left atrium, into the left ventricle, and then out through the aorta. What I want you to notice on this slide, what is so important, is the color of the aorta. The aorta is the pumper of the blood to the body. So if you can picture what color is this aorta, that's going to tell you what color your baby is. And so I want you to remember that, because today, as I mentioned, we are talking about our cyanotic defects. That means that the baby, understandably, would be blue or not as pink, not as well perfused with oxygen. And it's important to remember that as you also start learning about acyanotic heart defects. If the aorta, via the structure that has changed in the congenital anomaly, would not be red on a picture, right? It's not a literal representation. We know this is a visual representation. Then the baby is not going to be red or pink. So let's keep that in mind. So let's talk about Tetralogy of Fallot. Did you know that Tetralogy of Fallot is the most common cyanotic heart defect? I love little facts like that. I used to teach at Jeopardy during some of my teaching days, and this was one of our Jeopardy questions. Name this is the most common cyanotic heart defect. And someone would say, what is Tetralogy of Fallot? So tet means 4 in any language. Tet means 4, so it's going to be 4 defects. A VSD, which you can see is right here. Pulmonary stenosis, meaning that pulmonary arteries go away, is tight. An overriding aorta, the aorta has kind of taken over and had to push over into the other side. And then you have right ventricular hypertrophy, where that right ventricle is just too big. This can and usually is diagnosed on prenatal ultrasound. I caution you because, remember, Not every woman knows that they're pregnant. Not every woman knows that they are going to be, having a baby. Some babies are born before they have that ultrasound. Sometimes a pregnant person may choose to get one ultrasound and that's it. And maybe they don't see this during that ultrasound. So just keep in mind that we're not going to always know every single thing, right? Technology is amazing, but it's not always perfect. These babies can have cyanosis, difficulty feeding. They can have those TET spells. These babies require PGE1 to keep that ductus arteriosus open. If you watched our video last week where we talked about common cardiac medications, we talked about PGE a lot. We will review it at the end of this just because all these defects are going to require it, so I want to review it one more time at the end. And then of course we're going to have surgical repair. The big thing to recognize about these is that I've seen a baby with TET come down from mom baby, right? The baby was pretty much doing okay because there's enough mixing of the blood via the ductus arteriosus and the ventricle, right? The VSD allows some of that blood to mix, and so it's not always going to be this perfect situation. As you can see, our aorta is red, but it has this pink purple element down here. It's not that perfect shade of red that we want, and that's how we know that this is a cyanotic heart defect. Let's talk about transposition. I thought it's helpful to have these two pictures side by side because the aorta and the pulmonary artery are switched. Remember, both are those are A's, A away, that's my key thing here. They're both going away, but the pulmonary artery is supposed to be going away from the right side into the lungs to do their job, and the aorta is supposed to go away from the left side and go to the body. In transposition, they are switched. So instead of being crossed, they are parallel, meaning that the aorta, the thing taking things away into the body, is coming off the right side. And the right side's job is to have unoxygenated blood. So that means that our aorta is going to be blue, which means that this is a cyanotic heart defect. They are going to have severe cyanosis, respiratory distress, metabolic acidosis, and the only way that the baby is going to get oxygenated blood is via the ductus arteriosus. So transposition of the great arteries, transposition, TGA, requires PGE in order to keep the duct patent so that we can have that going on in there. Obviously, this baby's going to need surgery. They may have a balloon atrial septostomy, and then they'll have their atrial switch where they switch them and they put them in the right order. I've mentioned this in the past. I don't know how long you've been watching here. Cardiothoracic surgeons literally are life changers. So just something to keep in mind. So again, this is very, 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 very commonly caught on prenatal ultrasound, something to keep in mind. It does put a lot of stress on the lungs, which is why you're also seeing respiratory distress and metabolic acidosis. Pulmonary atresia. So pulmonary atresia has this absence of the pulmonary valve, and so we can't get that blood flow to the lungs, and so we can't get the oxygen. Again, this is going to cause your aorta to not be this beautiful shade of red, and they're going to have this mixing of the blood so that it can get in and get its oxygen. It has to almost have this kind of like reverse flow when you think about it, right? Because we have to get the blood somehow from the right side of the heart, which is unoxygenated, into those lungs. So we are going to require this PDA in order for that blood flow to happen. So the aorta is going to be full of unoxygenated blood with a mixture of oxygenated blood. So this is going to be more of a purple. I wish I was really fancy and had great names for all these colors. But when you think about transposition, it's like blue. And when you think about pulmonary atresia, it's going to be very purple. It's going to have mixing of oxygenated and deoxygenated. Also requires PGE1 and then ongoing surgical repairs. I also want to mention, probably should have said this on the first slide, that just like anything, the echo after birth is the gold standard. Echo is the gold standard confirmation of any prenatal diagnosis. So TAPVAR, I said I was going to tell you some stories. I took care of a baby with TAPVAR when I was 37 weeks pregnant, and it was pretty much the hardest day ever. And it wasn't diagnosed until he was 5 days old because there was other compounding things. He had NAS, meconium aspiration, and it was 35 weeks. So the fact that he was requiring a little bit of oxygen, a little modeled, right? This was over 10 years ago. So we were using the Finnegan scoring system instead of Eat, Sleep, Console. So you can remember modeling is one of those things on there that we're scoring them for. With meconium aspiration, you're going to have changes in your oxygenation. And so he was on a little bit of oxygen. However, by day 5, it's like those things should be getting better, and they weren't. So we did an arterial blood gas, and his PaO2 was like 30. I don't remember the exact number, but it was very low. So it's just something to think about, because then we did the echo and it was diagnosed. But because the structure of the heart can look very similar, it's the way that the blood is returning back into the right atrium. So pulmonary veins drain into the right atrium instead of the left atrium. So you've had this pulmonary blood, right? That's the pulmonary veins go back to the heart, remember? So instead of those pulmonary veins going back in with this glorious oxygenated blood and getting it out to the body, it's going to the right side. Tricky, huh? There are different kinds of TAPVAR. I also caution you that, so make sure you go and you can read more in depth into it. I just remember hearing it for the first time. I was, I don't know, 8 years into my career when that was the first time I heard about it. So it is a very interesting structure. It's also wild that this whole new restructure happens, but that's why the prenatal ultrasound is difficult. So this is why it's often seen more in the postnatal echo. We're going to see cyanosis, respiratory distress, pulmonary congestion. You can see why a baby with NAS, meconium aspiration, and 35 weeks could have been missed on this. And this is only treated with surgery. Obviously, we're going to get some PGE started, help keep that duct open. Truncus arteriosus is actually my favorite congenital heart anomaly because I love elephants, and the trunk here on truncus arteriosus looks like an elephant's trunk to me, and that's also how I remember it. So truncus arteriosus is a single arterial trunk that arises from the heart, supplying both systemic and pulmonary circulation. So look at your aorta in this picture, right? It's this purple. It's got some red in it. It's not that blue of the transposition, but what is happening is when you think of an elephant's trunk, they have like 2 holes at the bottom. So instead of having our side-by-side of our aorta and our pulmonary artery, we have one. So it's pulling oxygen and deoxygenated blood both to the lungs, which can then be stressed from the extra blood flow, and to the body. So the baby's going to be cyanotic. Again, when you look at the heart surgeons fixing these things, it's like, oh, we just like cut it in half with these little extensions on them. I know it's a way bigger deal than that, but that's what the pictures make it look like. You're going to see that the baby's relying on a large VSD here, and so these infants do require surgery to get this all put back together and have the blood flow going in the right way. Hypoplastic left heart. So this is when different parts of the left ventricle are underdeveloped, and then the aorta is often underdeveloped. What I really want to stress here is the idea of how much of a big muscle the left ventricle is. If you know anything about gravity, and I don't know enough to sit here and tell you about it, but gravity is a big deal, right? And so the left ventricle has to pump blood into the aorta against gravity because we're upright, right? Our artery is going up and out. So it's this idea of how hard that left ventricle has to work. So you can imagine that if it is weak, it is unable to pump that blood. And if sometimes with hypoplastic left heart, that mitral valve, right, the bicuspid valve, is also underdeveloped and sometimes closed, so which leads to the left ventricle being underdeveloped and hypoplastic. So we really rely on our ductus arteriosus to remain open for the mixing of blood coming back from the lungs. These babies, we do often know in utero, they are often the sickest, especially with severe cases of hypoplastic left heart, and it requires a lot of surgeries, and sometimes when it's really bad, these babies do get put on a transplant list. So this is one of the most severe. When hypoplastic left heart is severe, it is very, very risky. I always know when I heard I was going to get a hypoplastic left heart admission, I was nervous. So to take those nerves away, know what your PGE is going to do, know what you would expect your saturations to be doing, and the importance of keeping that ductus arteriosus open. Tricuspid atresia is the absence of the tricuspid valve. So that's on the right side of your heart. I learned this from new NICU nurses when I was teaching, and called, you got to try it before you buy it. So the blood goes through the tricuspid valve before the bicuspid valve. You can teach these old dogs new tricks. So when that's happening, when the tricuspid valve is underdeveloped, there's nowhere for that blood to get into that right ventricle. And remember, the right ventricle is getting the blood back to the lungs to get oxygenated. So it requires this VSD so that the blood can go on both sides to get into the right place. This, if you look over here, right, you can see what's happening in the right atrium. It's nice and blue, and it's like, where can we put the blood? You see there's an ASD, an atrial septal defect here. There's a VSD allowing the blood to get in here so that we can still get some blood out. But look at the aorta. What color is the aorta in this situation? It's very purple. So saying that, we know that this is a cyanotic heart defect. These babies often can have tachypnea, feeding difficulties. They require PG1 and then surgeries. I have always been transparent with you, and that's never going to change. I am not a cardiac ICU nurse. Never have been. There are many people out there. There are great resources for that. CCH Doodles on the socials is a great one to refer to. There are great, cardiac ICU nurses, I'm sure, that could tell you, pediatric cardiac ICU nurses. I don't know the difference in the surgeries. I've never had to do that. I believe in leaning into what we need to know and leaning into our strengths. So what I like to make sure I understand, and that's why we broke this week's teaching up into cyanotic and acyanotic, is what is cyanotic? What does that mean? How would I explain it to a family? And what would I anticipate if I'm the admit nurse or taking over for the baby? The first steps and the importance of the different assessment pieces I'm going to do. And that is PG1, right? PGE, prostaglandins, alprostadil, whatever you want to call it. If you have not watched last week's cardiac meds videos, I recommend you go back and watch them, but we are going to review it, right? The mechanism of action is it's maintaining ductal patency by relaxing the smooth muscle. So instead of these two sides coming together and being like, okay, we're done, we're going to patch each other up, it's going to be great, we're going to close this window forever, like a sealed window that can never reopen. Anyone ever had one of those? Instead, we're going to be like, okay, let's relax, we're going to keep these away from each other. It keeps it open, and to maintain this systemic or pulmonary circulation so that oxygenated blood can either get to the baby or the unoxygenated blood can get to the lungs to get oxygenated. We usually start at 0.01. I typically have seen a lot of 0.03 as my continuous infusion. We will see increased contractility, increased heart rate. You can see a lot of vasodilation. These babies can get really flashy hot. So hypothermia is something you want to watch for. And apnea. Apnea is a side effect of PGE. That's kind of your quick review. I want you to just keep in mind the importance of getting this started. If you work in a hospital that delivers these babies, maybe you deliver, stabilize, and ship. That's what we did at the first hospital I worked at. You want to make sure that you have a way of getting your PG to your bedside quickly, that you have your central lines prepared to go in. During admission, you want to be feeling your pulses, do your 4 extremity blood pressures, have those ready to go, and then get your PGE started. We want to talk about neurodevelopmental care because these babies are already going to be in a setting of decreased oxygen. And as we know, oxygen is going to go to our most vital organs first, right? Brain, heart, lungs, maybe our liver, our kidneys, probably not our guts so much. The Next Society had a very interesting post up about the importance of congenital heart disease babies and their neck risk because of this decreased blood flow to the gut. So especially if the baby's born prematurely and we have these confounding factors. So check out the Next Society. I do love them and they have great resources. We also want to make sure that we're doing good positioning. If these babies are in a PPHN crisis, you might be on extra medications, even INO. You're also going to be really watching them for these hypoxic injuries. And they may be on fluids for a long time. So what can we do for their nutrition, for their growth and recovery? Especially for some of these surgeries, the babies have to be a certain size to get the surgery. So we want to make sure we're helping them grow and develop. And of course, we have our parents here, right? Often these babies are going to have a long NICU stay. And something I want to make sure that we talk about is the idea that if you work at a delivery hospital where these babies are delivered, stabilized, and shipped, immediately we're having separation of mom and baby, which is not ideal, but that is the way that a lot of centers are set up, depending on your regional setting. And we need to take into mind what that means and how quickly could we get the baby to see the mom. Can the Mom come down on a stretcher? Can the baby go with the transport team via mom's room so mom can see them? Can we get pictures taken, footprints, record heartbeats, something of mom that smells good to be with the baby so that we can promote this bonding in a setting of a very traumatic event and a very big separation. There's going to be lots of NICU stays. Some of these surgeries, they look so big and they don't stay in the hospital for too long. And I'm like, how is that a thing? So just something to keep in mind, that the baby could be in the hospital for a long time. They may go home with specialized things. It was also Feeding Tube Awareness Week recently, and I was thinking about some of these babies that are going to go home after these major surgeries with alternate feeding methods. Have them get connected with other groups of families that have gone through this and find their support, and just see how you can best help them in getting them to take breaks as well. As we enter into our recaps, I wanted to leave this here. You can screenshot this, you can message me, and I will send this to you via email. Always happy to share resources. That's what we're here for, is to help each other. This is just a quick, how is it diagnosed, our most common symptoms, and what our treatment is. I want to point out that, again, probably the vast majority of these TAP bar might be the hardest one. They might be diagnosed prenatally, but if they're not, that gold standard is the postnatal echo. So check this out. So to recap, cyanotic heart defects impact oxygen. It impacts because of our structural abnormalities. Hypoplastic left heart, transposition, like I talked about, are very easy to detect on prenatal ultrasound. Some others may not be as easy because of the way the blood is flowing and our intrauterine versus extrauterine blood flow, which we are going to talk about in week 3 of February. So sneak peek, come back for that. We use our pulse oximeter, our 4 extremity blood pressures. We listen for murmurs. We've talked about murmurs a lot during January and how can we best hear them. We want to know what our PGE does, what we should be watching for with PGE1, how we can best support the baby, and then, of course, what is our long-term developmental outcomes? How can we as bedside nurses support that with good positioning, pain control, having parents present whenever possible, doing touch hold, having them have the healthy smells, doing oral care when allowed, so that we can improve the quality of life for these patients. Thank you for joining me for today's Teach Me Tuesday about cyanotic heart defects. Again, my name is Lisa Houston. You can find me here on YouTube and on Instagram and TikTok, where we do NICU education and fun NICU things. So I hope you'll follow along. Please make sure you are subscribing, and the more you like and follow, it is easier for you to find these videos from week to week. Have a great week, and I will see you on Thursday.